I'm excited to introduce the next paper and also the presenters and the authors. I'll just say that I used to think that I was getting, well, no, I still think that I'm getting old. But I just wanted to say that it's nice when I can say that the presenter is actually was one of my advisors, all right? So he might be older than me. But anyway, come on, Mike, and go ahead and start your presentation about health reform and welfare.
Okay, so the title of this paper is Health Insurance Reform and the Redistribution of Welfare, a Dynamic Life Cycle Analysis of Heterogeneity and Willingness to Pay for the Affordable Care Act. Now, let me just say my first comment on the paper is that I think they should change the title. I would make this the title. I would just say Heterogeneity and Willingness to Pay for the Affordable Care Act. I think that captures much more succinctly what the paper is about, because the core idea here is looking at heterogeneity amongst different types of people in their willingness to pay for the ACA. Now, and that's important because if we look at the prior work, you see that this paper is actually filling an important gap. There are two papers that have studied the implementation of the ACA and its impact on welfare in dynamic structural models. That was Pashenko and Pakaram and Jung and Tron, right? But in both of those papers, everybody has the same health process. So there's actually very little heterogeneity in those papers and no scope for adverse selection. If we look at the Aizawa and Fong paper, the very famous paper looking at effects of the ACA. Their main focus is on firms' decisions to offer health insurance and how it is affected by the ACA, something which the previous two papers I mentioned don't consider. In Han Ming's paper, he's got good and bad latent health types. So there's some limited scope for selection, but that's about it. They also have in their paper that observed health states evolve exogenously, and their paper is not really a life cycle model, basically because being single versus married and having kids versus no kids are just fixed types. They're not changing over the life cycle, and they don't look at heterogeneity in welfare. Talk about it. And I suspect that's because there's very limited heterogeneity in their model. There are the two other papers that develop dynamic life cycle models with insurance. That's Denardi, Pashenko, and Pakaram. A re-stud paper that's forthcoming. And there's another paper by Elena Capatina and myself. And these are life cycle models, full life cycle models with consumption and insurance choices. But neither of these papers model the impact of the ACA. In the first paper, people without employer-sponsored health insurance can buy private insurance where the premium depends on health and age. And since the premium depends on both health and age, their model does not have adverse selection. In my paper with Capatina, we do model selection into employer-sponsored health insurance, and we find there's, of course, advantageous selection. But we don't have an individual private insurance option in the model. So again, neither of these papers really addresses the issue of the welfare impacts of the ACA, right? So I think, I just wanted to lay out clearly where this paper contributes to the literature. So I think it's actually filling a very important gap. Now, so the key thing they're going to do here is look at the impact of the exchanges that were created by the ACA. So they're going to look at replacing individual insurance whose price depends on health with government subsidized community rated private insurance. And the focus of this paper is on the heterogeneity and welfare impacts of that policy. They actually are not going to look at the Medicaid expansion at all, right? They're focused on this particular aspect of the ACA, which is this introduction of community-rated subsidized private insurance. And you know, as I've discussed, prior work does not look at the heterogeneous welfare impacts of this policy. And in fact, it lacks enough heterogeneity to look at it sensibly. So the model they're setting up here has much richer heterogeneity than in the prior work. The prior work that looked at the impact of the ACA. In the model, they have 3 education levels. There are dropouts, high school graduates, and college graduates. And each of these is going to have their own life cycle income process. There's also an initial draw of the persistent part of income that you get at age 22, which is when the model starts. And this initial draw, which is highly persistent, generates heterogeneity in income within education types. So they have, you know, substantial heterogeneity in the income process. Agents in the model also draw their initial health status at age 22. There are 5 levels of health in the model. And their initial health status is drawn from a distribution that differs by education. So this is able to capture that less educated tend to be less healthy, but on top of that, you also get heterogeneity in health within the educating groups. And the final important aspect of heterogeneity in the model is that the probability of being offered employer-sponsored health insurance will depend on your income level. So the higher earning jobs are more likely to come with employer-sponsored insurance. So looking at how the model is set up, the men in the model, this is a model of men, right? They're aged 22 to 84, and they must retire at age 65. So there's no labor supply decision in the model. You just have income evolving exogenously. So both health and income evolve exogenously. As I said, there's 5 levels of health. Agents within each period, agents draw their employer-sponsored health insurance offer status. They're either offered it or not. And as I said, whether they're offered it depends on the income level of the job. Right? And the critical thing is that the agents who are not offered the employer insurance can buy private insurance. Now, in the baseline model, which they've calibrated to the pre-ACA period, the premium depends on health and age. And then when they do their experiments, they're gonna, of course, drop that, enforce that it can no longer depend on health. Now, in each period of the model, the agents get a medical need shock. So they call it ADA. This medical need shock has a mass at 0, right? So you may not have any medical need at all. But then it has a mean and variance that depends on which of the 5 health levels you're at. Okay? Now, the utility function in the model is a CRRA in consumption and a CRRA in medical spending if the medical need shock is positive. Okay. So now if you look at this term, and notice that the CRRA parameter is estimated to be about 29. So it's very large, right? So what this is going to do is that if you get a medical need shock, right, and if your medical spending is very low, then this thing's going to be a big negative. It's going to be the medical need shock is going to be painful, right? And then as you increase your medical spending, you're able to mitigate the pain of the medical need shock. So as you increase your medical spending, this term gets smaller, and if you crank it up enough, you can drive the term close to 0. In the baseline model, both the employer-sponsored health insurance and private individual insurance premiums are determined by the expected medical expenses of people who sort into each of those options. Now, the employer insurance premium is priced by pooling all the agents who purchase the plan, regardless of health advantage. On the other hand, the individual insurance premiums are conditioned on age and health status. And an actuarial constraint has to be satisfied within each age health group. They make this assumption that, and this is a simplification of the model, that the insurer only observes whether your health is either low or high. They group together the poor, fair, and the good, very good, excellent people, right? So the poor, fair people get one premium, the good, very good, excellent get another premium. And this, I think, is just technical because they couldn't handle solving for the actuarial constraint for all 5 groups. Because that's a hard problem in a dynamic model like this. So you get a common premium within each of these groups. And finally, the model has a consumption floor that captures in a simple way the array of benefits available to low-income people, like Medicaid, food stamps, unemployment benefits, etc. And that's a very common way of dealing with this, going back to the classic Hubbard, Skinner, Zeldas paper. Okay, now, so that's sort of what the structural model looks like. Here's some couple graphs of the model fit. Here's a graph of an employer-sponsored health insurance take-up rate by age. And what you see is that the young people sometimes don't take it up, right? So these young, healthy people, basically, about a non-negligible portion of them don't take up the employer insurance. So you get less than full coverage. Remember, this is conditional on being offered the employer insurance. But then once you're up to about 45, 50, practically everyone's taking it up. And the model captures that pattern pretty well. We can also look at the purchase of individual private insurance conditional on not having been offered the employer insurance. And let's see here. Matthew here, which is the solid line to data or is the dotted line to data?
The dots are the data.
The dots are the data, okay. So, and this is the 5, these are people grouped by income quintile, right? So each color is a different income quintile, and you see that the higher income people, not surprisingly, are much more likely to purchase the individual insurance if they're not offered the employer insurance. The take-up rate for the poorest group is only about 25%. Remember, these are income quintiles at each age. Because of the way the income process works in the model, it's stochastic. So you might be in one income quintile at one age and a different income quintile at a different age. So these are not the same people. So it gives a pretty good fit there. I'll come back to that in a minute. So now that they've fit the model, they're gonna look at an experiment where they bring in the ACA provisions. So under the ACA, households earning between 100 to 400% of poverty who were not offered ESHI are eligible to receive subsidized private insurance through the exchanges. And originally, the ACA imposed a tax penalty of 2.5% of income or $695 per person, whichever is greater, for households that do not hold health insurance throughout the year. And the ACA compliant individual market plans couldn't condition premiums on an individual health status, their health history, or their habits. But the premiums were allowed to depend on age in a limited way. But there was a constraint that they couldn't go up too much with age. And so basically we have community rating where the individual market premium is going to depend on the medical risk profile of everyone in the pool, in the exchange. So when they do their ACA experiment, they remove the dependence of the private health insurance premium on health status. The age constraint was that the ratio of the premiums for 64-year-olds to 24-year-olds couldn't exceed 3. Okay, so what happens when they do this experiment? So this is the first key picture here. So this graph is showing you the take-up of the individual private insurance for the healthy group and the unhealthy group. Right? So remember, they're defining unhealthy as the groups 1 and 2, and healthy as groups 3, 4, 5, in terms of the 5 health categories. So what you see is that, as I was saying earlier, in the baseline, you've got a lot of these young, healthy people who are not taking up the individual insurance. But once you introduce these subsidies, that green line shoots up, right? So you're getting a lot of young people, a lot of healthy young people now buying the private insurance. And that's important because what this graph here shows is the premium at every age for the healthy and unhealthy types. So in the baseline, of course, the premium for the unhealthy type is much higher, right? So that's the red dotted line. Premium for the healthy type, the green dotted line, is a lot lower. Right? when they implement the experiment, you go to a single community rated premium. That is the solid green line, and it's barely any higher than the initial premium for the healthy types, right? And that's precisely because you're getting this nice favorable selection of the young, healthy people into the individual market plans now. So that looks like a good thing. This next graph shows you how the take-up differs by income. This is split up. The different colors are high, medium, and low income groups. Matthew, is this income terciles by age?
No, it's high income is the top quintile, low income is the lowest quintile, and middle income is the middle 3 quintiles.
Oh, so you're just leaving out 2 and 4.
No, it's the middle 3 quintiles.
Oh, it's the middle 3.
Yeah,
Oh,
middle income is the whole middle.
Oh, it's
And
middle
these
3.
are quintiles conditional on not being offered ESI.
Okay, so you're leaving out 1 and 5.
No, 1 and 5 are, so the top income quintile is high inc, the lowest income quintile is low inc,
Yeah.
everybody else is middle income.
Oh, you're combining 2, 3, and 4.
Yes.
Okay. All right, so middle income is 2, 3, and 4. Okay, so what you see in this picture is that for the for the middle and high income people, the take up is very high, right? But the take up is rather low amongst this lowest income group. But the reason for that is that a lot of that group is actually below the poverty line, so they're not eligible for the subsidies. But under the actual ACA, it would be the it would have been the Medicare expansion that's designed to help those people. But as I said, what's that? Medicaid expansion designed to help. I always screw that up. But but as I mentioned, they're not modeling the Medicaid expansion in this paper. Now, okay, so having said all that, let me say I have 2 criticisms of the paper. How much time do I have? 6 minutes. Oh, great. Okay. So I have 2 critiques of the paper. Before I do, let me go back to what I forgot to mention. If we look at these graphs, over on the right side of these graphs is the willingness to pay for this ACA provision as a function of health and age, right? And what you see is that according to this picture, the healthy young people are willing to pay almost $50,000 for this policy, and the unhealthy young people are willing to pay $75,000 for this policy. Now, to me, those numbers seem very big. My sense is that present value of lifetime income for a typical person is something like $800,000, $700,000. I do those sorts of calculations sometimes. That's what I usually see. And so these look like very high percentages of lifetime income. Now, so I think that's implausibly high. And I think what's driving it is this utility function here, where this term here with the V of 29, those are going to be huge negative numbers if you have a health shock and your medical spending is low, right? So of course anything that increases your medical spending will reduce these numbers greatly, and you'll be willing to pay a lot of money for that. my criticism is that it seems strange to me to have medical spending in the utility fund. It also seems strange to me to evaluate welfare, the welfare benefit of insurance in a model where medical spending generates utility. So, I don't think we really get utility from medical spending. I would prefer a model where there's a derived demand for medical care. And that's actually really easy to do with the current setup. You could, all you would have to do to have a derived demand for medical care is let the health shocks cause your health transitions to deteriorate. Right? And then rig it up that medical spending mitigates that deterioration. So what I would do is just take medical spending out of the utility function completely. Let health shocks cause health transitions to deteriorate, and then just let medical spending mitigate that deterioration, and then you'll get a derived demand for healthcare. And my prediction is this doesn't require any new state variables. It's really easy to do. My prediction is I think the model will still continue to fit well, and you get these nice predictions about what happens to premiums and so forth. I think you'll get more reasonable numbers for the willingness to pay if you do that. So that's my main comment, really. I had one other comment, which is and this is much more minor, but it seems a little strange to me to have 5 health types in the baseline model, and then assume that the insurer can tell if you're within type 1, 2 versus within 3, 4, 5. And what that means is that private insurance is going to be a good deal for types 1 and types 3, and a bad deal for types 2 and 5. And if you look at the model fit here, that's why you're getting the green line a bit too low and the red line a bit too high. Right? So you can fix that easily just by letting the premium be a linear function of health, but constraining the coefficient on health to be less than 1, which is kind of like assuming there's partial observability of health. Yes. So anyway, I think what I really like about this paper is this point it makes about the positive selection into the individual market plans, which I think is quite important. But on the other hand, I'm skeptical of the willingness to pay calculations for the reason I stated. So I will just leave it there.
Thanks. Thank you, Mike, for that really good review of the paper, and thank you for having me here. I want to address your criticisms and comments first, then say a little bit more about other things that are going on in the paper or where it's going. Thing one on the title, if you think I'm a paranoid person, if you know me, Ahmed is the one who wanted that long title. When you said to shorten it, I thought you were going to go to my original one of just the first 2 bits. Ahmed, some of you would say that some people don't read past the abstract. Ahmed's very scared that no one's going to read past the title. And so he wanted the words dynamic, life cycle, and structural all in there so that editors would have no doubts about who to send it to or where it was going. With respect to your first main criticism of the premise of medical spending and the utility function, you are absolutely dead on about that high new value of like something close to 30 is driving a lot of what's going on. This makes people terrified of not having enough to or not being able to buy enough medical care to actually meet that. You can approximate that utility function, that term utility function, by just like it is infinitely steep until 1 and then perfectly 0 flat after beyond 1. Like there's very little there. Where is that estimated from? is trying to fit the gradient of intensive margin medical spending with respect to income. So what you see is that, because we have a non-homothetic utility function, you can say, okay, if richer people do buy more medical care, you can estimate elasticity there. And what you get from the math is that the ratio of new to row to new is approximately the negative income elasticity of demand for medical care. And if that comes out around minus like 1/6, then you get, and you estimate row to be something plausible like 4, suddenly you're at this insane value of row. The question of where did that come from? Why are we doing medical care as a consumption good? That utility form is lifted straight from Gennardi, French and Jones 2010. It's in there, they might say the tacked on section that sure looks like a referee asked them to do an endogenous medical spending specification. Some referee in the back is nodding saying, yeah, I asked for that. They get much different values, but don't explain the identification for where that comes from. But we thought we were a little bit safe in just using it. It would be better to have health be endogenous to medical spending. The complication comes in, my position from practice is that endogenous health is relatively easy with binary health. It's relatively feasible with binary health. It's feasible with continuous health. And then if you have non-binary discrete health, you need to make some very, very specific choices about how does a marginal increase in medical spending redistribute your future health state across multiple discrete states. It's one thing if it's continuous, it's entirely different if it's discrete. Also due to the way that the model is solved, it wouldn't add any state variables, but it would blow up solution time. So I don't expect you to have dug through the horrible computational appendix, but there would be some elements of that would be very, very, very difficult. So it's been discussed. So it's hard. That's why we didn't do it. It's a terrible excuse, but I'm kind of saying it. We've talked about it, and we decided to put it off for basically the next paper, in which we're looking at different questions. But it is certainly in there. Your second point about grouping the health states. So this is partly doing the good health and bad health in 2 tiers. It's actually not a technical constraint at all. With one line of code, we could flip it down to 5 tiers of insurance, and it would actually be easier to solve. Because there's less adverse selection going on. That you've got people in a tighter bound of willingness to pay for insurance in any one given period, and so the convergence to equilibrium premiums is almost instant. It's pretty fast as is, like 3 iterations to it. You can do it in 2 or 1 iteration if you do it that way. We didn't do it so that we could explicitly have adverse selection. So your criticism on the last slide on one of your last slides of this grouping makes it a good deal for people in fair health, or a bad deal for people in fair health and a bad deal for people in excellent health. That's exactly what we were going for. So we would say feature, not a bug, because what you can show is that even within the healthy types, that if you just do community rating and you don't do anything else, you can show the flow of excellent health people and excellent health young people into buying IMI, even absent anything else, and you get that reduces premiums, and that will cause even more people to buy insurance. And so it was intentionally done. But I really appreciate that point. The other big thing is the potentially implausibly high willingness to pay values, and I've thought about this too. Ahmed is a little more sanguine about it, and I worry about it a little bit. I would point you to the relatively steeper slope of that decline early in life, that it starts out high, has a steep decline, and then kind of flattens out a little bit, the decline flattens out. What's going on there is that so much uncertainty is going on in the early life cycle, that permanent income shocks are bigger as you sort into your career. Health shocks, you might suddenly end up with serious chronic illness that expresses in your mid-30s, but really it's the permanent income component or persistent income component that sorts itself out there. And so there's just so much uncertainty left when you are 22 and you enter this model that, yeah, you've got a big willingness to pay to make a lot of that go away, to get insurance on your insurance. Fine, okay. So I think it's a lot, but I don't think it's implausible, given the patterns that we have. But you're absolutely correct as to where it's coming from. And a lot of it's driven by higher income people being willing to pay a lot for it too, because there are just two wrong things happening from, it's kind of there before the grace of God go I. In a perfectly rational forward-looking model, everyone knows that these small probabilities exist, and with sufficiently high risk aversion, they're going to be taking into account and really, really valuing insurance against even unlikely events. That said, where are we going with it lately? We are actually de-ACAing the paper, trying to take some of the emphasis off of the ACA itself, because referee feedback has been ACA is passé. That's so 2010s. We don't know what the future holds. Hey, we've got a panel going on that this afternoon. So we're trying to make this a little bit more general and about channels of adverse selection and moral hazard that can exist in this structure. The channel of endogenous health is something that we'd like to get in there as well, and then use the ACA as a vehicle or example policy to show those channels rather than being this top line thing that people might be bored at by now. The other thing that either you didn't catch or were too polite to point out is that the model lacks extensive margin moral hazard. The probability of zero medical needs and thus equivalently buying zero medical care is fully exhausted in the model. It does not depend, I mean, it depends on your health and your age, but it doesn't depend on your income. It doesn't depend on your insurance status. In the data, that is the farthest thing from the truth. It is big. And I ran those numbers a little bit late and I realized, oh no, that's where a lot of it's hiding. We have experimented with trying to put in, to endogenize the extensive margin of medical care. The way you do this with the consumption utility form is to put a shifter term on that. You add in like M plus alpha over eta goes in there. So for sufficiently low values of eta, the person says, well, I don't need to buy any more medical care. I'm already hitting my target of 1 in that, and they can have endogenous zeros. It gets, what we've found is that there's almost a trilemma that is, I don't have full time to explain right now, where it's very, very difficult to fit the extensive margin of moral hazard, the willingness to pay for insurance as expressed by ESI and IMI uptake or purchasing rates, and intertemporal saving behavior all at the same time. But there's a tension among those three that, and Mike would just say, well, is that more evidence that your utility form is wrong, that you've got the preferences wrong, and thus you can't hit everything all at once? And quite possibly, yes. But as they say in Mars Attacks, 2 out of 3 ain't bad. Am I out of time or am I? Yeah, then I would say Mike pointed to that young people having a slightly lower insured rate even when offered ESI. That's actually one of the other little mysteries in the estimation is why they have actually such a high ESI uptake rate but such a low IMI uptake rate. Where the young people who are being offered ESI, I'm no longer young, I'm kind of middle-aged now. But some of you are 25, you're being lumped in with your 64-year-old colleagues when you pay for ESI, even if your employer is subsidizing it. It's not actually that good of a deal for you. And the IMI pre-ACA was much less robust, but there were products that existed. Getting people to be so much more willing to buy ESI than IMI is actually a little bit hard to fit. And young people is actually a little bit hard to fit. But I'll pause there and take questions. Thank you so much.
Great paper, thanks, I enjoy a lot. I have a question, I mean, this mean willingness to pay, if I understand correctly, this is the average across all people at that age, right?
Conditional on not being offered or not offered in
Not
that manner.
not being offered, but I wonder if it's possible to estimate the willingness to pay for the marginal patient who would switch to ACA-based insurance, because that's what, because people who are already taking insurance without ACA, they may have a pretty high willingness to pay to begin with, and so this kind of masks the marginal patient who would be switching to insurance because of ACA, and that's where I think the comparison, the policy effect is most relevant.
Yes, so that can be separated because in the paper, we decompose by component of the ACA, saying, well, what's community rating, what's the insurance subsidies, what's the individual mandate, blah, blah, blah. So you can say, who are the people who would switch but for the individual mandate? Who are the people who would switch who wouldn't switch but for the subsidies? Figure out, isolate who they are, and then say, what's their willingness to pay?
Yeah, and their willingness to pay should be lower than the average, right? Because otherwise they would have chosen some kind of insurance.
It will be lower for two reasons. So for some of them, it will be extremely high, because these are people who were relatively low health when the ACA kicked in, and for them, this is an amazing deal, right? You get to be pooled with much healthier people now. They're gonna be willing to pay a lot. There are people who took up insurance after the ACA solely because of the individual mandate, right? They were right on the margin of buying it without the mandate, but then the penalty or the threat of the penalty would cause them to push in. They're actually going to have a negative willingness to pay. But then there are people who, because other people switched into insurance because the subsidies, the premiums came down, inducing them to go in, they've got a positive willingness to pay for the ACA. So, yeah.
And then my last question is, did you model survival effects through medical care?
No, so health and mortality are fully exogenous. I mean, it goes to the exact same thing, that if people have it, if you have health in the model, or endogenous health in the model, you would implicitly also have endogenous survival. The other thing that I would say is that putting endogenous health into a model that also has consumption is very, very tricksy, because you need to specify, at some point you need to say, what is the level of consumption at which you are indifferent between consuming at that level and being dead. And that is makes people really uncomfortable.
Multiplicative utility, I guess.
Say it.
Multiplicative utility functions.
I'm glad you're doing this modeling. It is very complex. I'm curious, I didn't see any mention of the tax subsidy to employer-sponsored insurance in the presentation note. Is it in the model? Because that would explain some of the low take-up by younger people who have lower incomes and their correlation.
Yeah, so no, I will admit the tax structure that we have in here is facile. The tax system can be improved, without much difficulty. But we also, I would say that because we don't have the employer side stuff like Isaiah and Fang focus on, some of that is some of the benefit of that is reaped by employers, right? And so you won't get it exactly right when you have a one-sided, you have labor supply model, but not a labor demand model, so yeah.
My other comment is that an earlier figure was showing that your model of take-up rates was really badly fitting the higher income groups. It was driven by functional form there. And that's, if you go back to the one of the earliest slides and that one right there with the dots. The next one, the next one, that one. That's really badly fitting on the older ages.
Yeah, I mean, it's really hard to get a model that explains why anyone over age 50, when offered a subsidized premium from their employer, wouldn't buy insurance. I should say this model has no taste chops. We're not, putting in anything that says, oh, there's just some random, trembling hand chance that you just don't do it. Or maybe, throwing that in, or just reporting error would do it. Yeah, no, if you did this, if you flip this into log terms, to go back to an earlier paper, this looks like a terrible fit at those old ages. But it's, in a dynamic model, it's really hard to explain why people wouldn't buy that insurance.
Other questions? I have one question. So Matt and I actually went back and forth with questions on this paper because I presented it to my graduate students. But going back to Mike's question about expenditures and utility function, because I think I kind of asked you, because sometimes you talk in the paper about M being expenditures, but sometimes you talk about it as consumption.
Yeah.
And I think your response to me was that prices are set to 1 in medical care. Does that relate to Mike's question at all?
No, because it would, if we put a different price, then we simply would have estimated a different distribution on ADA. It would have been absorbed in that direction. The price of medical care relative to consumption in the model code can be different from one. Like we could put in medical inflation and say, well, let's look at this 10 years on, and now medical prices are just higher. What's the effect now? But we haven't done that.
Would you then have M in the utility function or N times P?
They would have M, they would have the quantity in there, but then we would measure in the data M times P. Yeah.
I may have missed this, but thinking about different reasons the model's not fitting as well for the older adults. Are you accounting for the fact that they may have received insurance through a spouse, or they might be
Yeah, it's just,
they might be eligible based on disability or Medicare coverage?
yeah, so this is the definition of ESI insured right here is do you have any insurance, any or comprehensive medical insurance conditional on being offered ESI? So this version includes men who get insurance through their spouse or the VA or unlikely to be Medicaid if they're being offered ESI, but it includes that. If you do versions where you take out people who are offered what I call exogenous health insurance, that they are insured for some reason that is not within the model, this shifts down very slightly by like 0.5% to 1% at any given age. But no, we specifically make sure that we allow for other sources of insurance. I will say that question applies even more strongly to individual market insurance, because over there are a lot more people who are they're not being offered ESI, but they're insured. For the purposes of that figure, we've labeled those people as buying IMI. In reality, who are these relatively high income men who, relatively conditional, not being offered ESI, who are buying IMI at this high rate? Men who have a high income spouse who's insuring them through that. If you change the specification of the definition of IMI uptake to be much more restrictive, those pre-ACA IMI insured rates go way down, and you end up estimating a much lower row. which then implicates a much lower new, because new is, the product of row and a parameter that we effectively estimate. So, and that greatly affects the willingness to pay because it makes people less terrified of the worst case scenario. So you were dead on correct that defining what does it mean to be insured and how it's really being modeled in data is a key operator here.
Have you thought about modeling like the family unit as the unit for the demand for insurance?
Pass. No, so yeah, family dynamics are hard. So again, I'm so sorry to pass it off that way. We are treating people in this model as if they are a single person. So we're using a single person's income and a single person's health shocks. In reality, most people are partnered and married. In reality, about half of households have children arrive, semi-exogenously, semi-endogenously. Introducing dynamics in that is possible, I would say computationally possible if you set aside estimation. In the background here is that on a very high-end desktop computer, solving this takes 1 hour per iteration. Solving it on a server takes 20 minutes per iteration. If you introduce family household dynamics, you are increasing the state space significantly. And so I think you would need to set aside some of the ambition of estimating parameters, taking some parameter estimates from the literature or from, say, what Matt and Ahmed did before was good enough, we'll use those, let's solve it once. This kind of the macro model approach. If it's gonna take 2 days to solve, we've got a finite number of shots at this. And a 1 hour computation time is like right at the limit of like, is this really an objective function or is it a one-shot model? So I know this is somewhat a mix. So Johnny gets me, and a few other people in the room get me. Other people are looking at me like I'm making excuses here, but okay, yeah.
But between like 25 and 35, it's not like health's, like income's going up, that's one reason why you might see increased take up of ESNJI. Health is getting worse over time, but like how much worse is it getting between 25 and 35? I bet, my conjecture is that a large part of it is like family formation and.
Yeah. You've got more reasons to behave better and to take less risks between 20 and 30. Yes, absolutely. But that also begs the question of what is the utility function within the household, and like how do I value my children's utility? Or are like there are models where children are literally just parasites that take some of my resources, and there are other ones where their utility enters directly into mine. In my wedding vow, that was my description of love of my wife. Specifying that is a whole box, and there is a world of people who do that. But I think it's not for here yet.
All right, I think we have built into this session a break in between. So you have until 11:30. If you wanna mingle, get some coffee, talk about research, meet new people.